Hi, hello. I'm Leah Solm and I'm dermatology consultant at Great Ormond Street Hospital. I'm not sure why my name showed out so small, but I think I've done some last second change to the slides. So I'll be talking about benign vascular tumors today, and there are many. However, I will concentrate my talk on those four. So infantile hemangiomas, pyogenic granuloma, congenital hemangiomas, and then tufted angioma and Kaposiform hemangioendothelioma. So we start with infantile hemangiomas. I've noticed that they have been named incorrectly many times, and the fruit is very popular in the name. So you will see strawberry hemangiomas, raspberries, cherries, but the correct name is infantile hemangioma. They are the most common vascular tumors of childhood, and their incidence is 5 up to 10% of Caucasian children, and even more common in babies that were preterm. So if their birth weight is less than 1,000 grams, the incidence is 22 to 30%. They're more common in patients with multiple gestation, so where they were twins or triplets, more common in girls, in older maternal age, and whenever there was a placental abnormality. So we have 4 types of infantile hemangiomas, and the first one is the superficial type. That one is very easy recognizable, and it looks it does not go deeper into dermis and the subcutaneous tissue. It used to be called capillary hemangioma. That's another term that we prefer to avoid, and we call them superficial infantile hemangiomas. The deep hemangiomas are the ones that can appear, which usually pose the most diagnostic difficulties. So they look like a bluish compressible masses. You can see sometimes the very superficial, the very fine telangiectasia on the top. The mixed one is the mix between superficial and deep. And then we have arrested growth or minimal growth infantile hemangiomas, which usually appear as a telangiectatic patch. But how you can recognize them is that they usually have little papules at the periphery, they seem to prefer acral, so distal acral areas. I usually say that the most important thing to remember from this talk is that infantile hemangiomas are not present at birth. I will show you the precursor lesions, but as the whole lump, they are not present at birth. They grow very quickly for the first 3 months, and usually 6 to 9 months, usually before that even, they reach their maximum size, and then they start regressing. And regression can take years. 4 years up to 10 years, but the 80% of them, the regression is complete by year 4 of age. So how do precursor lesions look? Parents will usually tell you that there was a patch or like a bruise present or bruise-like lesion present at birth, but they can look, they usually can be paler and have telangiectasia, or they really can look like a bruise, and that's why they get mistaken. Distribution pattern, so we differentiate between focal and segmental lesions, even though there is an indeterminate pattern as well. So they sort of look segmental, but they're smaller in size. But focal means that they have well-defined focal point, and the segment that they follow a particular segment, which I will show you later. Why is this important? Because the segmental hemangiomas can tell you that there are some other underlying anomalies. And the first one is the Faces syndrome, which is an acronym and stands for posterior fossa anomalies, H for hemangioma, A is for arterial abnormalities, and that means usually the brain arteries, cardiac abnormalities, and eye abnormalities. And there has been the Stern S, so you can see face or Faces syndrome in the literature, because they can have sternal defect or supraumbilical raphe as well. So how do we work up these children? So if you see a segmental hemangioma of face and neck, you need to do MRI of head and neck. So actually you need to do MRI of head. That is for posterior fossa anomalies. You need to do MRA head and neck. That's for arterial abnormalities. At GOSH, our radiologists know, so when I request MRA head and neck, they will do the faces workup, but it's worth checking with your radiologist how they do it. All the patients need echo and ECG, and that usually is the first investigation you need to do, because they might need a general anesthetic for the MRI, MRA, and you really want to know whether they have any cardiac abnormalities before they have the general anesthetic. And then you need to refer them to ophthalmology. So the segment, the map of segment has recently been revised, and you can see there have been 4 segments described, and faces syndrome is the most associated with the segment number 1, and in 41% of patients who have infantile hemangioma in this segment have faces syndrome. But also in the large lesion and the lesions that go over 1 or 2 or even 3 segments. They also added the scalp segment, so you can have faces without a face, but that has been added as well recently. If you have a plaque hemangioma on the, if your patient has a plaque on the plaque hemangioma on the lower back, then we would think about lumbar syndrome. This actually syndrome has few acronyms: sacral, lumbar, and pelvis. I sort of use lumbar, and it means lower body hemangioma, urogenital abnormalities, ulceration, myelopathy, bony deformities, anorectal malformations, arterial abnormalities, and renal abnormalities. So how do these patients need to work up? You need to do ultrasound of the abdomen for the renal abnormalities, MRI of the spine, and that needs to be with contrast. And you just do the whole spine. Now, MRI of the limbs. I did have a few patients that had smaller leg, and it was obviously cooler, but otherwise it was fine. And I did request MRI limbs once, and even at Gosh, they said it's really difficult to do in tiny children. If it's not causing problems, I leave it now to vascular surgeons to decide what needs to be doing. So complication, the most common one is ulceration, and they can occur on the lesions that rapidly expand, so the focal lesions, but also on the plaque type hemangiomas. And sometimes parents will tell you that the first sign would be this whitening of the surface, or even they will say grayish area. And one thing to remember is they're terribly painful, and often, especially if they're located over the lip, these patients might have difficulties feeding, faltering growth because of it. So they need treatment early. And the treatment depends a little bit on the appearance of hemangioma. So if it's a plaque hemangioma, you will not rush in with the propranolol because there's nothing really to shrink. However, in the round one, that because of the rapid proliferation they had in ulceration, propranolol will be required. So we usually use the silicone dressing, alginate, and then pad it with gauze because they are painful. Obviously, if they're on the lip, you can't do the dressing on those areas. If you use oral propranolol, depends a bit again on the shape, but literature has shown that the lower doses, for example, 1 milligram per kilo per day, might be better. And then we use Flaminol, topical antibiotics, and topical steroids to heal them faster. Rarely oral antibiotic, but I did combine propranolol and oral steroids sometimes but short course of oral steroids, so a week, maybe 2, to aid the healing. Airway hemangiomas, so the child would present with a stridor, and usually at the age of 4 to 8 weeks, when it expands. And what has been noted is that it's most commonly associated with hemangiomas in this beard distribution, so that is the segment 3 down here. So please take history about any stridor, especially if you see this type of hemangioma, because you can see what this poor child has been left to breathe with. Propranolol works really well. Sometimes, if you're worried, combination with steroids, but they need an urgent referral to ENT. We'll usually refer to ENT and just help them with the treatment. Periocular infantile hemangiomas obviously warrant early treatment because some of them have potential to threaten or permanently compromise the vision. And larger lesions in this area have the highest risk of amblyopia, but even the smaller lesion can disrupt normal visual development. So those are the ones that you need to treat early as well. In the terms of investigations, usually the deep hemangiomas are the ones that pose the most difficulties, but it's important to take the history. So was it present at birth? Did it appear later? Was it sort of in the time, but they appear naturally because they always follow the same, they always have the same natural cause. So ultrasound can be useful, rarely MRI actually. Ultrasound can give you, if you have a good sonographer, can give you enough information. And the biopsy is needed only if your diagnosis is unclear, and usually done in specialist centers. So this is not something you will do a punch biopsy. It needs interventional radiologists due to the risk of bleeding. The good thing is they are GLUT1 positive. So there are not many tissues that are GLUT1 positive, apart from the infantile hemangioma. So usually we will term them as GLUT1 positive lesions. Then you have to decide which one are you going to just watch and wait, and which ones you're going to treat. And since 2008, we have finally, I think it's one of the biggest discoveries in pediatric dermatology in the last probably 20 years. It's a treatment, it's very cheap, easy to tolerate. We knew the side effects previously because it has been used since, oh, that one went quickly, since 1952. So it has been discovered in 2008 as a serendipitous discovery in France and totally changed how we manage the hemangiomas. One thing I really would like to stress is that we did say they go down, but that doesn't always mean that they're left behind the normal skin. And that's why it's so important to treat, especially facial lesions. You know, when you have a visual impairment or infantile hemangioma over the lip, there is no, you will not think twice about treating, but also all the facial lesions, especially the nose, middle face, forehead, anywhere you have fine curves, for example, like around the lip area, require treatment. And the oral beta blockers have the best effect on growing infantile hemangiomas, and 80% of growth is done within first 3 months. And then by 5 months of age, the majority of them stop growing. So we really don't have much time, and early treatment is really required. I've seen quite a few times that it was said, oh, but you know, we will wait until 1 year of age. If they don't go away, we will give propranolol. No, start treating very early. So in the UK, we used the British Society for Pediatric and Adolescent Dermatology Consensus Guidelines. They were published in 2018, and they helped to standardize and unify the treatment with propranolol in the UK. I will not go through that because you can go through the guidelines, but mainly the indications for them are anything on the face, so vision, airway, nose, lip, auditory canal, ulcerated hemangioma, again, as we said, with a lower dose, risk of permanent disfigurement, and spinal cord compression by the infantile hemangioma. There are a few things you need to be careful. For example, for phasis patients, they need a lower dose of propranolol before you do the MRI. And the reason is because if they have a narrowing of the artery, you can cause low blood pressure and stroke. But we say that they can get a quarter of the dose before the MRI results come back. Atenolol is a selective beta blocker that we occasionally use and can be used as an alternative, but usually useful in patients that have sleep disturbance on propranolol, and the starting dose is 0.5 milligrams per kilo per day, and then we increase it to 1 milligram per kilo per day.